Hello, welcome. We are on multiple choice question sessions in pharmacology and we are doing the next session. Next nice session, 10 questions and 5 options for each particular session, and we shall see some important concepts in pharmacology with the help of these questions. Question number 1. Proton pump inhibitors are most effective when they are given A. after meals, B. shortly before meals, C. along with H2 blockers, D. during prolonged fasting periods, and E. at bedtime. We are speaking about proton pump inhibitors, which are going to affect the secretion of the gastric hydrochloric acid. And as you know, the secretion of the gastric hydrochloric acid is going to happen when you take your food, and for the digestion the secretion is going to start. If you give it shortly before meals, it's going to be more effective. In addition to this, there are more bioavailability issues. There are more issues with the omeprazole breakdown in the stomach, and this is why it's the best way to give it shortly before meals. So after meals, shortly before meals, along with H2 blockers during prolonged fasting periods, and at bedtime, we choose shortly before meals. Let's have a look at the answer. Yes, it's shortly before meals. So please remember, whenever you prescribe a proton pump inhibitor, ask the patient to take it 15 minutes or 30 minutes before the patient starts his meals. Let's go to the second question. Yes. Which of the following is correctly matched? It means there are pairs and there's matching. Dimercaprol, iron. Calcium disodium EDTA, arsenic. Penicillamine, copper. Dysperioxamine, lead. And protamine sulfate, B12. If you have prepared your heavy metals and poisoning very well, you could easily solve this question and immediately you can come to a conclusion. If you have prepared, still we have another option, is going to each particular answer and analyzing it and discussing some issues related to it. A is dimercaprol. Do you remember dimercaprol? It is BAL. It is British anti-levisite. And this was specifically developed by the British against arsenic poisoning. That's the war gas. And this is for dimercaprol iron. This doesn't match. Next is calcium disodium EDTA and arsenic. Obviously it doesn't match. We just now said dimercaprol arsenic. Next one is penicillamine copper. So it's a heavy metal poisoning with copper. Penicillamine, yes, it's quite likely. Let's wait and see. Next, dysperioxamine, lead. Dysperioxamine, do you remember anything? Dysperioxamine is a chemical antidote to treat iron toxicity, and this is why dysperioxamine lead is not correct. The last one is protamine sulfate B12. Usually you don't get B12 toxicity in this way, and moreover protamine sulfate is an antagonist, is an antidote for heparin. So this is how we went through the various options and we could get some additional information. So the answer is most likely to be penicillamine, copper. Make a list of the heavy metals and try to write the antidote against the heavy metal and have this list with you, maybe 4 or 5 heavy metals, and on the top of it also make a list of drug and its antidote. Is going to help you this sort of multiple choice questions. I'm sure you will do it. Don't forget, note it down. Next question, question number 3. Mechanism of action of tianeptine in the brain is. What's the mechanism of action of tianeptine? Let's go through the options. A. Selective serotonin reuptake inhibition. B. Selective norepinephrine reuptake inhibition. C. Selective serotonin reuptake enhancer. D. Selective dopamine reuptake inhibition. And E is serotonin norepinephrine reuptake inhibition. This is something different. This is something atypical. Whenever you want to use an antidepressant drug, the aim of the treatment is to increase the level of amines. And if you want to increase the levels of amines, you need to inhibit the reuptake or the uptake. And this is why when you think of antidepressants, we are most likely to choose from the options is selective serotonin reuptake inhibition, selective norepinephrine reuptake inhibition, selective dopamine reuptake inhibition, and selective norepinephrine reuptake inhibition. But I'll point out to you something. There are 4 various options which is taking into consideration almost all the amines, and when 4 options are looking similar, I don't think this is going to be the option, because we are talking about tianeptine. It's an altogether different drug, and please remember, mechanism of action of tianeptine is it is an enhancer of selective serotonin reuptake. So it's trying to act in an opposite manner to the usual mechanism of action of antidepressants. It's got some other activities, that's why it proves to be an antidepressant. But as far as the serotonin reuptake is concerned, it is an enhancer of the serotonin uptake. It's exactly opposite to all other antidepressants. You need to remember this is something atypical. Remember the name of the drug, tianeptine. So that's your answer. Selective serotonin reuptake enhancer. This is a rare question, and this is an important question, and this is atypical. We go to the next question. Question number 4. Which drug leads to sense of warmth? There's atorvastatin, ezetimibe, resins, niacin, and fibrates. Let's go through all these drugs, then you'll realize atorvastatin is an HMG-CoA reductase inhibitor, and this drug is one of the best tolerated agents. You can expect hepatotoxicity with this drug, and you can expect the myopathy. I hope you remember myopathy. When we come to myopathy, let's take name of 2 more drugs which can lead to myopathy. There can be niacin, there can be fibrates, which also precipitate myopathy, right? Resins are the drugs which are acting in the intestine, and ezetimibe also in the intestine. So whatever adverse effects will be related to these drugs are more likely to be local adverse effects which are concerned with the gastrointestinal system. And sense of warmth, the drug has to produce something very systemic. Resins are not absorbed, so you don't expect this with resin. And with ezetimibe, there are no much adverse effects. It's comparatively safer agent. So that's gone. So you're left between niacin and fibrates. If you remember something, niacin leads to prostaglandin release. And due to the prostaglandin release, you get the sense of warmth because there's vasodilation and there can be sweating, and this patient gets a very typical sensation of heat coming out of the body. And you can pre-medicate the patient, or you can manage this patient with the use of NSAIDs, which decrease the prostaglandin synthesis. Niacin releases prostaglandins. So please remember, that's the most commonly experienced adverse effect by the patients. Niacin produces sense of warmth. So that's the answer. That's niacin. Let's go to the next question. Question number 5. All of the following drugs cause renal failure except cefaloridine, amphotericin B, cefoperazone, gentamicin, and cisplatin. Good, we got this question, because with the help of this question we are getting a list of drugs which can precipitate renal failure, which can produce renal damage. So it's our revision of nephrotoxic drugs. As you know, cephalosporins are nephrotoxic. So we have cefaloridine, cefoperazone, 2 drugs here. So cephalosporins are nephrotoxic. We can remember this. Next, amphotericin B. Yes, it's a nephrotoxic agent, and that's the greatest fear, using amphotericin B for longer periods of time. Next one is gentamicin. That's an aminoglycoside, and I hope you know it's the most nephrotoxic aminoglycoside. You need to take care if the patient suffers with diminished renal function. You'll have to monitor the dose of gentamicin by various ways. And next one is cisplatin, which is an anti-cancer agent, and it is very nephrotoxic agent. So let's revise which are the nephrotoxic drugs. We have cephalosporins, amphotericin B, gentamicin, and cisplatin. It's really difficult to choose from these 5 options because we know that cephalosporins are also nephrotoxic. Before exactly choosing an option, let's try to know what's the difference between the nephrotoxicity of aminoglycosides and cephalosporins. Most probably, the aminoglycosides produce tubular necrosis. You might have to solve such questions on some other session. That's why I'm giving you a hint. Aminoglycosides produce tubular necrosis, whereas cephalosporins predominantly produce interstitial nephritis. Please remember the difference between the nephrotoxicity of aminoglycosides and cephalosporins. Aminoglycosides, tubular necrosis. Cephalosporins, interstitial nephritis. Now let's think about the option. There are two drugs, cefaloridine and cefoperazone. Our answer seems to be between these two drugs because we are sure amphotericin B, gentamicin, cisplatin, all are nephrotoxic, all can cause renal failure. So it means that we have to choose a drug which is less likely to produce renal failure. We want to choose the better option, the best option out of this. Let's try to choose between cefaloridine and cefoperazone. I'll go to the next slide. Look at this. It's cefoperazone. Cefoperazone is less likely to be nephrotoxic, and this highlights one more fact. The other option, that's cefaloridine, is most nephrotoxic, cephalosporin. Now what's going to happen is either you remember cefaloridine as most nephrotoxic, or you remember cefoperazone is comparatively less nephrotoxic. So cefoperazone is not known to produce renal failure. It can be used if at all you want to use. Cefaloridine is most nephrotoxic, cephalosporin. So all of the following drugs cause renal failure except the answer is cefoperazone. Let's go to next question, and that's going to be question number 6. All of the following statements are true regarding losartan. Losartan is an angiotensin receptor blocker, ARB. The type of receptor is called as AT1 receptor. I'll write it here for you. ARB is angiotensin receptor blocking agent. What is the type of angiotensin receptor? It's called AT1 receptor, angiotensin 1 receptor. Let's go to the options. Losartan. It is a competitive angiotensin receptor antagonist. Yes, it is correct. We just now said it's an ARB. It has a long-acting metabolite. Yes, correct. It acts for a long time. Losartan is a long-acting drug. Associated with negligible cough. What do you feel? There are two drugs in this group, antihypertensives. One is ACE inhibitors and second one is ARBs. And both of them, they act in the same pathway, if you remember. Let's do it. For example, angiotensin 1 gets converted to angiotensin 2. The name of the enzyme is ACE, angiotensin converting enzyme. And this is the place where the angiotensin converting enzyme inhibitors act. Correct? This angiotensin 2 is going to go to two places and is going to act. Number one is blood vessels. I'll write the short form, blood vessels. And angiotensin 2 is going to produce vasoconstriction. The second side, the angiotensin 2 is going to act is the adrenal cortex. And from there, you will get the secretion of aldosterone. I'll write only aldo. This aldosterone is going to produce sodium retention, water retention, and potassium loss. Is it okay? So, this is the place for action of angiotensin 2. Let's use another color. Angiotensin 2 here and angiotensin 2 here. What is the place where angiotensin converting enzyme inhibitors are acting? They are acting here. When ACE inhibitors act here, they are inhibiting the enzyme angiotensin converting enzyme. But there is another enzyme which is same, another name which is same as this enzyme. That's called kinase 2, and it's responsible for breakdown of bradykinin. I'll put here BK. BK is broken down by the same enzyme. And when you inhibit this enzyme, bradykinin accumulates. Because bradykinin accumulates, there are two manifestations. Number one, dry cough. And the second manifestation is angioedema and the rashes. I hope you remember the pathway, and now it will be easy. Losartan is associated with negligible cough. Do you agree? If you want to produce cough, you should act here and bradykinin should accumulate. This is not happening because losartan is not acting here. Losartan is acting down here. So associated with negligible cough is a correct option. You cannot choose this. Next option is causes hyperuricemia. And the last option is has less chances of producing angioedema. So what about angioedema? Do you agree? Look at this. You must inhibit this, then there will be bradykinin accumulation, then there will be angioedema. Losartan is less chances of producing angioedema. So it is a competitive angiotensin receptor antagonist. A is correct. It has a long-acting metabolite is correct. Associated with negligible cough is correct. Has less chances of producing angioedema is correct. So what remains is hyperuricemia. And losartan is not known to produce hyperuricemia. So all of the following statements are true regarding losartan except causes hyperuricemia. Let's go to the answer. Yes, we are right. We analyzed, we are right. We understood the renin-angiotensin-aldosterone system, and we understood the difference between losartan and ACE inhibitors. That's ARBs and ACE inhibitors. Let me take you to the next question. The next question is question number 7. Gemcitabine is effective in head and neck cancers, pancreatic cancers, small cell lung cancer, soft tissue sarcoma, and carcinoma breast. You need to know this. You need to read this chapter. Prepare a list of drugs and what are the common cancers for which the drugs are used. Gemcitabine, the best option amongst these options, I'm taking you to the answer, is pancreatic cancer. It can be used for small cell lung cancer, but the most appropriate answer out of all these 5 is pancreatic cancer. Gemcitabine is effective in pancreatic cancer. We go to next question, question number 8. All of the following drugs can cross placenta except. It means we have to choose a drug which does not cross placenta. Think about it now. First is phenytoin. You know about phenytoin. Phenytoin produces, it's called hydantoin syndrome, fetal hydantoin syndrome. So it has to cross placenta. It will cross the placental barrier and it will produce toxic effect in the fetus in the form of neural tube defects. Next one is diazepam. Yes, diazepam can cross placenta. Next one is morphine. Obviously, morphine crosses placenta. Pregnancy is a contraindication. Next one is heparin. What do you think? Whenever such a question comes, you think about what are the other drugs in this group. Heparin is a parenteral anticoagulant and oral anticoagulant is warfarin. Are you remembering anything? I am reminding you, warfarin is fetotoxic and heparin is not. If there is a pregnant woman who needs anticoagulation, drug of choice is heparin. So please remember this. The next drug is methimazole, and methimazole is an antithyroid drug and it cannot be used in pregnancy. If you want to use something, you should go for propylthiouracil. Methimazole cannot be used during pregnancy. You need to use the other drug. I hope you remember propylthiouracil. It has got less protein binding. So if you want to give an antithyroid drug to a pregnant woman, drug of choice is propylthiouracil. So you cannot use methimazole also. So when we went through all the options, we understood phenytoin, diazepam, morphine, methimazole. All of them, they can cross placenta. They can be fetotoxic. We are left with heparin. And I hope you remember, heparin is the answer. If it's a pregnant woman, you need anticoagulation. You cannot give oral anticoagulants. We have to manage with heparin. I hope it's quite clear. You got some of the drugs which can cross placenta and which can produce fetotoxic effects. That's question number 8. Go to the next question. Question number 9. Mechanism of action of sodium nitroprusside is increased cyclic AMP, increased guanylate cyclase, calcium channel blockage, blocks chloride channels, and blocks angiotensin. Let's remember what is sodium nitroprusside. Sodium nitroprusside is a vasodilator. It dilates both arterioles and venules, and it could be used in the management of hypertensive emergency, hypertensive crisis. And it dilates the blood vessels. If you think of other drugs which dilate the blood vessels, there is alpha blocker prazosin. Mechanism will be blockade of alpha receptors. You have angiotensin converting enzyme inhibitors, and how they are acting is already on the board here. They are decreasing the angiotensin, and that's why the effect on the blood vessels will be less. You have ARBs, again they are acting by the same mechanisms. You have calcium channel blockers which produce vasodilation by the mechanism of blocking the calcium channels. Look at that. So sodium nitroprusside is not coming under any of these vasodilators. So how it must be acting? It acts directly on the blood vessels. It's a direct action. And it has to do something, liberate something, generate something which is going to have vasodilator properties. And I hope you know cyclic GMP is a very important substance, and finally it leads to the release of the nitric oxide. We say there are some drugs which release nitric oxide. I hope you remember about hydrolazine, minoxidil. So we are discussing about the direct vasodilators, and we could come to the conclusion that it's about cyclic GMP. Now let's go to the option once again. Increased cyclic AMP? No. Increased guanylate cyclase? Yes, right. That's the enzyme. And finally you're going to get cyclic GMP accumulation. Calcium channel blockade? Obviously no. Blocks chloride channels? Not at all concerned with the question. And blocks angiotensin? No, is going to be the ARB, angiotensin receptor blocker, which can block the angiotensin. So the answer should be increased guanylate cyclase as per the analysis we did. And I take you to the answer. Yes, that's the right answer. Increased guanylate cyclase. So please remember, sodium nitroprusside, direct vasodilator, increases cyclic GMP, releases nitric oxide, useful for hypertensive emergency, has to be used as continuous intravenous infusion because it has got very short duration of action due to rapid metabolism. So I think we revised sodium nitroprusside. We go to the next question, question number 10, the last question on this session. All of the following belong to the steroid receptor superfamily except vitamin D3 receptor, that's vitamin D, thyroid receptor, retinoid receptor, epinephrine receptor, and estrogen receptor. The knowledge of the receptor pharmacology is important. You know, most of the receptors are present on the cell membrane, and for some drugs the receptors exist. The receptor is the response element which is present in the nucleus. So there are few drugs for which you have nuclear receptors, otherwise most of the receptors are on the cell membrane. This way, if you think about various drugs, you have an option here, epinephrine obviously cannot have the receptor which is inside the cell, and it's not at all related to the steroid superfamily. Whereas if you go to rest of the drugs written here, vitamin D, vitamin A, thyroid hormones, and estrogens, something which is not mentioned here is also androgens. They are from the steroid superfamily and they have got a similar kind of receptors. For example, the substance comes and there is an area where the substance combines, then there is dimerization of the structure and it goes and acts on the response elements, which finally leads to protein synthesis. That's a common mechanism of action for vitamin D receptor, vitamin D3 receptor, for retinoid receptor, for estrogen receptor, and for thyroid receptor. Epinephrine cannot be the answer for this question. There is another way to look at this particular question. Read the options and you can find out the odd man out. Vitamin D and vitamin A. At least two vitamins, put them together. Thyroid, estrogen. Both of them are hormones. Put them together. Epinephrine neither belongs to any vitamin. Epinephrine nor belongs to any hormones. And this way you can get the odd man out. That's epinephrine receptor. Let's check what's the correct answer. Yes, epinephrine receptor. So we revise some receptor pharmacology. I am sure this session was useful to you. And when you are doing these pharmacology sessions, you are revising various chapters in pharmacology. That's a good way of doing it. That's a logical way. Solve the question, think about the various options and formulate your concept. But it's equally important to go to the topic proper and address it properly. It could have happened during your undergraduate days. You did not pay attention to much topics. It happens. But this is the time you can go to your undergraduate topics, revise the topics, and make use of the pharmacology video lectures. You can pick up a lecture if you get a difficulty in solving a question. Don't just look at the answer and leave it. Go to that particular chapter, observe that video lecture only for that particular part, and many of the concepts will be more clear, and then you can crack your competitive examination. I hope you're going to do it, and My good wishes are with you. Thanks for listening.